The Institute of Data and Analytics, or IDA, is a multidisciplinary research organization at the University of Alabama that focuses on the science of data and analytics for evidence and methodological-based research. The mission of the IDA is to promote the creation, transformation, and distribution of knowledge through data and analytic sciences for the advancement of data research and intelligence. IDA activities include internally led research, engaging in cross-campus and cross-university collaborations, and developing and supporting industry partnerships. The Institute engages in all phases of the analytics cycle, from study design to data collection and management, to analysis to implementation and ongoing monitoring. We leverage the Culverhouse College's pedigreed technical academic programs in statistics, operations management, and information systems in combination with the college's traditional business programs to work with external organizations to find and implement solutions to their most pressing problems and challenging issues. In its 9-year life, the IDA has worked with partners in industry and government on dozens of analytics projects over a wide range of applications. Today, we will describe one such partnership about which we are particularly enthusiastic.
Thank you, Dr. Cochran. Something we've worked hard to do at the Institute is to build an organization that thrives at the intersection of academia and industry. Through interdisciplinary efforts, our students, faculty, and staff participate in work that is impactful on multiple levels, be it to our stakeholders, the scientific community, and oftentimes society at large. One of our most prominent relationships at the IDA is with the Alabama Medicaid Agency. Through this collaboration, we've been able to bring together researchers from across the University of Alabama campus to engage in principal challenges relative to the agency. These have included things such as forecasting enrollment, generation and monitoring of risk scores, and evaluating quality of care, just to name a few. We often think of Medicaid agencies as the insurer of the underserved. However, when we look at the makeup of enrollees, we see the AMA insures over half of all of the youth in Alabama. And for this age group, it is vitally important to have appropriate access to health care. This specific endeavor focuses on using analytics to understand and ultimately empower access to dental care providers throughout the state. Because of this project, we can better identify which providers accept Medicaid enrollees and recognize which populations are at increased risk of poor health outcomes due to poor physical access. Not only have we worked to provide solutions to these challenges, we've acted to empower our colleagues at the Alabama Medicaid Agency so to continually adapt the process to ever-changing conditions.
The University of Alabama's IDA is involved with several projects with the agency's analytics division. These range from risk scoring our Medicaid recipients for help with proper case management to developing quality incentive programs for our providers, into the topic of this presentation, access to care. With almost 25% of all Alabamians at any given point being eligible for Medicaid, access to care is not only important for the agency, but for every citizen in the state. Limited access to adequate care not only has poor implications on population health of our recipients and state, but these access to care issues can also have a significant consequence for taxpayers, as recipients that have medical conditions not identified and not managed at early stages are typically more expensive to serve. So I believe the GIS framework built by the IDA empowers us to address this issue in a more proactive manner.
So before going into details about our framework, let's talk about what's currently done at other state Medicaid agencies. So in this screen clip summarizing existing protocols measuring access to care, you'll notice that in the first 2 lines, that many states focus on travel time and distance between the provider and the beneficiary's home. And some states focus on the ratio to physicians and enrollees, which is usually counted within a county of each state. So we feel that measuring physical access in this manner has limitations, which can lead to ineffective strategies to promoting care among Medicaid beneficiaries. So some questions like, what if some providers are reluctant to provide care to Medicaid beneficiaries, which is well established in the literature? Should we look at all licensed Medicaid providers the same, right? What if a major metropolitan area spans several counties and you have beneficiaries willing to travel from one county to another to seek care? And lastly, what if you have a particular provider in a neighborhood or census tract that's within a 15-minute drive of a dense number of Medicaid beneficiaries? Can this provider service so many patients? So unfortunately, we believe that existing access to care protocols for Medicaid agencies cannot address these questions. So we set our framework to address these limitations using evidence-based approaches published in the literature. So in this slide, you'll see our general workflow for the framework. This visual is just really a simplification of the complex framework. The main components of this framework were built using Python with Esri's ArcGIS ArcPy library and several SQL-based libraries like PyODBC and SQL Alchemy, which actually play a larger role in analyses. So due to the magnitude of the data, some models are also scheduled to run on a monthly basis and queued in the table so that the framework can be more responsive for analytic requests. And the complexity of the framework is simplified for our stakeholders using a GUI or a geographical user interface, which can put parameters in answering several simple questions. The user can kind of get the analysis computed more efficiently and quickly without having to see all the code. So thereafter, the results are exported as a static map or to a database where it's visualized from the application using Tableau. So due to the time constraints of this presentation, we will mainly focus on the aspects of the framework that address the limitations of existing protocols, which we'll discuss in the previous slide. So one of the key challenges facing most state Medicaid agencies, including Alabama, is a fair number of licensed providers perform little to no service for Medicaid beneficiaries. The reasons for this discussed in the literature are varied. There's a lot of them, but most state agencies recognize this problem. We believe that including some analytic proxy of an FTE or full-time enrollment in analyses will undoubtedly inflate it if you don't include it and provide a false sense of security. Moreover, not including it will mask the providers who do perform a fair amount of services and probably more deserving of incentives. So to better account for this issue, we leverage an approach used by actuaries in healthcare to appropriate funds to Medicaid programs. In short, we examine face-to-face encounters for all licensed providers. We determined the normal provider encounter rate, then divided that normal rate by the observed encounter rate for each individual provider that generated a normalized score. So this slide shows an example of what a typical encounter distribution looks like for the Alabama Medicaid Agency. As you can see in this example, we have a designated floor and a ceiling for our scoring rubric. Administrators provided their expertise to establish the floor, where in this example, we would just say 12 encounters, face-to-face encounters, doesn't count as a provider. This means that for a provider to count, they would need to at least have 13 encounters a past calendar year for them to be considered in analyses. As you can see in our example, there is a significant number of physicians that are essentially not counted. Conversely, a provider can become so overwhelmed that it is debatable whether they can maintain providing high quality care if they see too many patients. For this reason, our model has a ceiling. Looking at both y-axes in this graph, you will notice that a small proportion of our providers account for a significant amount of healthcare costs. This relationship is common for most, if not all, Medicaid licensed provider types for Alabama Medicaid Agency. The family of floating catchment models are the core models used in the measurement of access to care to account for many of the limitations that we discussed in earlier slides, especially with patients traveling across administrative borders in areas where the population is dense. In short, the model is a two-step model where the first step is establishing a catchment, like 30-minute travel time around the area, around the provider, and then we will sum the number of enrollees within that catchment. The result, the first step, is an initial provider to population ratio centered around each provider. For the second step, we aggregate the initial ratios around each population point, which is usually displayed at the census block group level. The result after the second step is the overall accessibility score for that census block group. Moreover, if there is an existing utilization data, we can generate a decay function so that access is weighted higher in areas closer to the centroid point within each catchment area. Based upon evidence in the literature, the downward log logistic decay is one of the better models when measuring physical access to healthcare. The visual in this slide highlights an example using publicly available hospital data in the US and US Census data for the population. This would be an example of an outputted image that Medicaid would use to evaluate access to care at the state level. And this slide is an example of an outputted map showing urban areas in Alabama. These are one of the more common urban areas of interest for the Alabama Medicaid Agency. In this example, you'll see an outputted map showing the rural areas of interest, with the black belt being kind of one of the primary areas. And if a Medicaid agency wants to examine differences in access, should a provider come on board or drop off the roster, there's also an area of the framework to help administrators for simple planning management, where we can remove or add providers to give a deeper sense of access to care. As a case example for this presentation, we can briefly discuss one application among dental providers using our framework. This past year, Medicaid was faced with a potential problem of a high proportion of aged providers. With the decline in utilization of dental visits during the COVID pandemic, there was a greater sense of fear within Medicaid of what would happen if aged dentists decided to retire due to low utilization and reimbursements. So the Medicaid analysts used the framework to assess the impact of access. Though we cannot divulge the specific details of the analysis that Medicaid used, because it is proprietary to some extent, we want to screen share an article replicating analysis using publicly available data, which is published in the CDC's Preventing Chronic Disease Journal. In this article, you will find detailed methodology along with code so that our analysis can be reproduced. Now that I briefly summarized the framework, or at least some of the reasons how our limitations are accounted for, let's hear from two Medicaid analysts, Thera and Narenjan, who will discuss how they use the framework in their workflow.
Narenjan, Carmichael, and I work very closely with the IDA on some of the GIS projects. When I started with Medicaid 4 years ago, we were just beginning to use the GIS framework. Initially, our work focused on counting providers by location to determine if we had an adequate number of providers to service the recipients in each of those locations. We then started using the framework to generate maps for our annual report. Now our work has evolved into using the framework to address dental access to care for our Medicaid recipients. We're actually working on producing an outcomes-based paper that focuses on our findings derived from the GIS framework.
Aside from the paper that I just mentioned, I have utilized the data generated from the IDA's GIS framework to create dashboards that aid in visualizing dental access. Medicaid's management team and dental director Dr. Danny Rush use these dashboards to identify providers for targeted outreach purposes. The additional insights gained from the framework has really been beneficial in understanding the potential implications of retirement among Medicaid licensed dentists and our Medicaid recipients' accessibility to dental care.
Ongoing efforts are looking at the development of a prescriptive model for incentivizing new providers. In particular, if we have a known budget, the location and ages of existing providers, and some estimate of incentives and how these incentives might entice new providers to practice in underserved areas, we want to help decision makers understand how they can allocate those funds to reduce gaps in accessibility. So to do this, we're using linear programming. So this is some of the notation. We have set of provider locations, set of customer locations, and we have a set of existing providers. And we have parameters specifying the budget, the number of providers that currently practice at particular locations, demand at the various locations, and some information on the maximum distances that a customer may travel to visit a provider. We also have an estimate of the cost of adding a new provider, and this can relate to that incentive amount that would be provided to entice those providers to practice at new locations. And ultimately, what we're trying to do is to figure out the number of new providers to add, or in this case, incentivize to practice at a location J, to minimize a maximum difference in accessibility. So this is that base linear programming model, and we can look at different variants of this, and we are looking actively at different variants of this. So this is kind of a base linear programming model, and our objective is we want to minimize the maximum difference in customer accessibility. One thing that's unique is you'll notice that we have the two-step floating catchment area kind of equations, or the structure of that built into the model. So when we're looking at constraint sets 2 and 3, that supply to demand ratio and the customer location accessibility definition, that is from that formulation. And again, ultimately, we're trying to solve this, taking into account that likelihood of people to travel to certain areas to minimize that maximum difference in accessibility. Regarding the impacts of the dental project, the insights from our work are used to support decisions regarding the allocation of Alabama Medicaid Agency's dental budget of approximately $93 million. Looking beyond finances, this served as an important proof of concept for the process that we have developed on tackling provider accessibility. It's helped stakeholders acknowledge biases that exist in current processes, and ultimately started a dialogue about how we can incorporate this type of workflow into our decision making. Looking beyond dental, AMA is looking to apply the framework to prenatal care and hospitals. And aside from the financial benefits, the insights have the potential to improve health outcomes, particularly for the youth and children in the state of Alabama, which we regard to be the future of the state. As with any project, there's going to be challenges. So some of the core challenges that we faced First, just helping stakeholders step out of the comfort zone and kind of get away from this is how we've always done things. In this case, we're dealing with very large data. So also in this case, helping stakeholders understand that with this magnitude of data, we might have to be using estimates for certain things instead of getting pinpoint accuracy in all dimensions. A major challenge with this product, since we're dealing with healthcare data, is the sensitivity and being able to make sure that we have the proper controls and to make sure that we can protect that data, of course, is a major challenge. There's some restrictions on the tools that the analysts for AMA can use. Again, some of that lending itself more to security concerns. And then finally, progress can be somewhat slow because there's many layers to this organization. And to get changes, often there's a chain of approvals that needs to be done. So the size and the scope of this organization can make things a little bit, slow to move through the system.
Dr. Freeman has provided an excellent summary of the immediate benefits of the IDA's partnership with Alabama Medicaid on this project. However, successful execution of this project is also generating far-reaching long-term benefits for our state. By focusing on systematically improving the dental health of disadvantaged youth in Alabama, we improve the overall health of these youth. This means they are able to attend school more consistently and put more thought and energy into their academic assignments, which increases the likelihood of their academic success, the overall graduation rates in the state, and the proportion of Alabama's youth that pursue post-secondary education and training, which improves the quality of the Alabama labor force, which attracts new business to Alabama and supports expansion of businesses already located in Alabama, which dramatically improves the economic health of the state, currently ranked 45th nationwide in per capita income, which generates greater tax revenues, enables the state to provide more services for its citizens, and further enhances the attractiveness of the state to business and industry. This project is also portable and scalable, and we will investigate taking this approach outside of Alabama. We're very excited about the immediate and long-term benefits that are being generated by this project, and we look forward to expanding the project and extending its benefits. Thank you for viewing our presentation.